Good morning, everyone, and welcome to this week's Thyroid by MD session. As March draws to a close, let us take a moment to celebrate our 4th anniversary. Since the inception of the last days of March in 2020, this platform has been dedicated to disseminating novel research in thyroid nodule and thyroid cancer care. It's my pleasure to say that over these years, we've facilitated more than 200 sessions that have been watched in over 80 countries with international leaders, and today's session is no exception. Today, we're privileged to have Dr. Ramona Dadu with us. Dr. Dadu serves as an associate professor and faculty director of clinical research in the Department of Endocrine Neoplasia and Hormonal Disorders in the University of Texas MD Anderson Cancer Center. With a degree from Romania, followed by a robust training and fellowship in the United States, Dr. Dadu has been an influential force in the field of thyroid cancer. Her focus on systemic therapies and advanced thyroid cancer has led her to work closely with multidisciplinary teams, fostering improvements in patient outcomes on an international scale. An active leader in multiple therapeutic clinical trials, Dr. Dadu's extensive publication record and invitations to speak at prominent conferences underscore her standing in the medical community. She holds memberships in several key organizations, including the American Society of Clinical Oncology and the American Thyroid Association. Our discussant today, Dr. Michael Xing, comes with an equally impressive resume. As founder, dean, and chair professor of the Southern University of Science and Technology in Shenzhen, China, and professor of medicine emeritus in Johns Hopkins University, Dr. Xing's contribution to thyroid disease research is unparalleled. He is widely recognized for his work in molecular mechanisms and genetic basis in thyroid tumors, notably contributing to the understanding of BRAFV600E and TERT promoter mutations. His efforts in the clinical translation of research have garnered over 2,500 citations, reflecting his profound impact in the field. Dr. Xing's leadership extends through his involvement in numerous prestigious committees and editorial roles. His accolades include multiple awards that speak to his status as a pioneer and a thought leader. Together today, they will be giving us a great opportunity to listen to what's new in the surgery after BRAF directed therapy associated in improved survival in patients with BRAFV600E mutated anaplastic thyroid cancer. I am personally looking forward to listening to this presentation, and I'm going to give the control to Dr. Dadu so we can kick off this webinar.
Good morning, everyone, and thank you so much, Dr. Gonzalez, for such an amazing introduction. I was tasked with reviewing one of our recent collaborative paper that was accepted in Thyroid late last year, and that's this experience of a neoadjuvant approach in anaplastic thyroid cancer. This is a very, before that, my disclosures are here, but most importantly, I want to mention that I'm not a surgeon, so any technical comments or questions regarding the surgery, hopefully some of the surgeons here could jump in and help with that. 10 years ago, everybody was used to seeing this particular slide when one was discussing anaplastic thyroid cancer. And in 2013, we used to say that anaplastic thyroid cancer is the deadliest of all cancers, that is a rare disease. And because of all of that, the advances were quite limited, leading to this survival, which sounded quite grim, with patients living from 9 months if they had a stage 4A to almost 3 months if they had a stage 4C anaplastic thyroid cancer at diagnosis. And I can tell you today in 2024 that there is truly some hope ahead for some patients with anaplastic thyroid cancer. And I will try today in a few slides before moving on presenting our paper to show you that there was a really exciting 10-year journey in anaplastic thyroid cancer. And yes, I can say today that there have been major improvement in survival in patients with anaplastic thyroid cancer. Here on the left, you can see an update in 2020, a paper presented by Dr. Maniakas in German Oncology, showing that over time, the survival of anaplastic thyroid cancer has improved. These years here represent major changes in treatment of anaplastic thyroid cancer. The 8-month historical control has improved to 10 months after introduction of a very specialized group treating anaplastic thyroid cancer at MD Anderson, but also introduction of BRAF-targeted therapies in the treatment of anaplastic thyroid cancer. And that survival has shifted to 16 months after 2017, when we started to introduce immunotherapy in the treatment of anaplastic thyroid cancer. After 2019, specifically in BRAF mutated anaplastic thyroid cancer, we started using a different approach to where, in addition to targeted therapy, in addition to immunotherapy, we have introduced the concept of neoadjuvant approach, where one will go and remove the primary tumor after initial response. And the update that was just presented by Dr. Hamidi in Thyroid Journal a few months ago showed that in this patient with this kind of approach, the survival is more than 5 years. I'm going to try to get you to how we got there. First of all, we started to understand that ATC may arise de novo, but also from pre-existing, more well-differentiated or poorly differentiated thyroid cancer by acquiring several more aggressive genetic abnormalities. The most common genetic abnormalities in anaplastic thyroid cancer are BRAF mutations present in about 45% of our patients, followed by RAS mutation in about 22 to 25% of our patients, and then coexisting mutation in TP53 in 60%, in TERT promoter mutation in about 40%, and the PI3 kinase 12%. Then understanding the molecular landscape, signaling pathways, and immune environment in thyroid cancer led to development of several treatment strategies, either as monotherapy or combinational approaches. And then it took a couple of optimists around the world to say that it's no longer the time to focus on only cytotoxic chemotherapy and radiation therapy in the treatment of anaplastic thyroid cancer, but maybe it's time to take that leap of faith and move in more modern molecular and immunotherapy type of approaches. And in 2014, the BRAF trametinib trial in anaplastic thyroid cancer was started, leading to approval of the trametinib for anaplastic thyroid cancer after this cohort basket trial of 16 patients with anaplastic thyroid cancer showed a 69% response rate and an overall survival of 80% at 1 year. There was an updated efficacy analysis of the same cohort after 4 years of follow-up, showing that the median overall survival on patients receiving the trametinib was about 14 months, with a median progression-free survival of 6.7 months. Early on, we have noticed very significant and very quick responses to BRAF-targeted therapies. However, acquired resistance becomes a problem. And as you saw from the trametinib trial, the progression-free survival remained quite short because of these acquired mutations. We have started using the combination approach of targeted therapy along with immunotherapy to try to bypass some of these resistant mechanisms. And in anaplastic thyroid cancer with a BRAF mutation, we have started using the combination of a BRAF MEK inhibitor along with a PD-L1 inhibitor. The trial presented by Dr. Cabanillas, combining an immunotherapy agent with a targeted therapy agent, depending on mutational profile of patients with anaplastic thyroid cancer. Specifically in those with BRAF mutated anaplastic thyroid cancer, there was significant tumor shrinkage in patients receiving the triplet therapy with an overall response rate of 42% and an overall survival that was not met, but a 2-year overall survival in the triplet drug of 67% compared to a historical of 32% in patients receiving the 2-drug regimen without immunotherapy. And then the next shift was to understanding where the surgery can be incorporated in this approach to try to help patients from acquiring this resistant to kinase inhibitors. In 2019, we presented this patient and our first 6 patients who were able to have a BRAF-targeted therapy followed by surgery. And we have shown at that time in a limited number of patients that the 18-month survival was 62%, and patients were doing excellent many years down the road. So that led to this study that I'm going to take a little bit more time to present today. It was a more extensive evaluation of our patients treated with the BRAF-targeted therapy followed by surgery. This is a single-center retrospective cohort study. All patients with diagnosis of BRAFV600E mutated anaplastic thyroid cancer who received the BRAF-directed targeted therapy for at least 1 month were included. All patients who received BRAF-targeted directed therapy were either a BRAF and MEK inhibitor with or without combination checkpoint inhibitor immunotherapy. In our practice, the BRAF inhibitor is stopped 1 day prior to surgery, and MEK inhibitor is stopped 3 to 5 days before surgery. And both BRAF and MEK inhibitors are started again 5 to 7 days after surgery. Our groups were divided in 3. There was a first group that included the neoadjuvant plus surgery approach. What that meant is the patient had to have definitive surgery after receiving neoadjuvant BRAF-directed therapy. We had a second group of patients with no surgery. Those were the ones who were started on BRAF-directed therapy but did not receive surgery. And then a third group of upfront surgery when patients received definitive surgery before starting BRAF-directed therapy. And in this study, definitive surgery was defined as intent for total or near total resection of thyroid disease in the neck. The scoring system used for morbidity is shown here. I'm not going to go over the details of this, but just to point out that this scoring takes into account multiple factors of tumor aggressiveness in the neck, and is considered mild with a score of 0 to a score of 4, where its tumor is deemed completely unresectable. The patient population of this study included patients that presented at MD Anderson from 2017 to 2021. There were 248 patients seen during that time frame, of which 74 patients had a BRAF mutation, and of which 57 received BRAF-directed therapy for at least 1 month. And this was the study population for this study. There was 45 patients in which BRAF-targeted therapy was initiated, and out of those, 32 were able to receive surgery. So just to point out that for everybody who had an intent for BRAF-directed therapy, about 70% of those patients are able to move on and receive surgery. This was the baseline characteristics of the three groups. What I want to focus a little bit more is on the neoadjuvant surgery group. This included the most patients, 32 patients with an age of 61, with an equal split between male and female. What I want to point out as well that the majority of these patients had stage 4C disease. About 37% has had stage 4B disease, and we did not have any stage 4A disease. The majority of our patients did receive immunotherapy. 84% received a triplet of BRAF, MEK, and immunotherapy treatment. And half of our patients received post-op radiation following the neoadjuvant approach and surgery. The response to BRAF-targeted therapy is as expected. The diameter of the largest neck lesion was reduced by a median of 61%. And to put that into more visual numbers, the largest neck lesion decreased from a median of 5 centimeters to 1.9 centimeters. This is showing the RECIST change, the waterfall plot of the RECIST change in target lesions. And this figure here is showing the change of the median largest neck lesion from the initial CT compared to the pre-op CT, with everybody having a very significant reduction in tumor size. When looking at the morbidity score, you can see here the majority of our patients had a significant change in their morbidity score. If you recall, unresectable, severe, and very severe patients are those who are deemed to have a very morbid surgery if they were to do so. But eventually, after BRAF targeted therapy, these patients were all able to achieve a pretty significant change in that surgical morbidity score. How does this translate for us in practice and for our patients? And this is a pretty significant change. About 80% of our patients had at least unresectable disease due to common carotid encasement or vertebral fascia involvement, and had severe morbidity expected to require extensive surgery, laryngectomy, esophagectomy, and tracheal resection. Out of those 25 patients who have required such an extensive surgery, only 2 of our patients actually went on to receive a laryngectomy, and 1 patient received a tracheal resection. Most patients had a reduction in the morbidity score to mild morbidity, 70% of them. So this was quite impressive to see how much of clinical and surgical benefit one may achieve by using the neoadjuvant approach. The adverse events by using this approach resulted from either the neoadjuvant BRAF directed therapy. Most of the side effects are as expected with these drugs. 44% of our patients required a temporary drug hold or dose modification during the neoadjuvant period, but there were no significant toxicity. Surgical complications, 4 patients had surgical complications, 2 developed neck abscesses, 1 had an ischemic stroke after the surgery, and 1 had a hypothyroidism readmission. And here is a very busy slide, and I'm going to try to spend a bit more time on this to explain what this shows. But this is comparing on the left the overall survival of patients who received neoadjuvant surgery in the red, compared to those who received upfront surgery. Those were the patients who never received the BRAF targeted therapy. And compared to those who received the BRAF-targeted therapy, but they were unable to move to have the surgery performed. And although in the neoadjuvant group, the overall survival was not reached at the time, one could see a significant improvement in overall survival in these patients. Similarly, on the right panel, progression-free survival was significantly improved in patients receiving neoadjuvant surgery, 34.2 months, compared to those with upfront surgery, 14.7 months, compared to those who received targeted therapy but do not have surgery done. This is another very interesting point and important point that came out of this paper. About 60% of our patients who underwent surgery had a pathological ATC complete response with only PTC remaining in their surgical specimen. And you can many times hear our surgeons that they do these surgeries and the tumor is almost gone. And our pathologist tells us, oh, there was just a small a few millimeters for foci of PTC remaining. So quite impressive. When looking at those patients who had only PTC in their specimen, the ones that had an ATC complete response in the black, you could clearly see that compared to those who didn't have an ATC complete response, the overall survival is much improved. So if you're able to have a surgery, but also a pathological complete response in the final specimen, the overall survival at 12 months was 100%. A clinical trial using this approach is currently undergoing, and it's almost close for enrollment. So more coming up soon in a more extensive prospective cohort. And so far we are seeing similar results, and I'm sure that these findings will be replicated in a very in a prospective fashion as well. I'm going to say that this really takes a village. This is the Facilitating Anaplastic Thyroid Cancer Specialized Treatment Plan at MD Anderson, who works tirelessly to care for our patients. And I'm here speaking on their behalf, and thank you all for making such a huge difference in the care of anaplastic thyroid cancer patients. Thank you all for your attention.
Thank you so much, Dr. Dadu, for an incredible presentation and remarkable work on the field. We're gonna jump just quickly to Dr. Xing's presentation. And before we do that, I do want to encourage the audience to send any questions they might have so we can get to them before the end of the hour. Dr. Xing.
Very good, thank you. Well, this is a wonderful talk, Ramona. Great, wonderful work. Very creative thoughts, very creative design before the research, and very exciting results after your research. MD Anderson Thyroid Cancer team, of course, is really in my career life always my admiration. So you guys produce exciting results one by one over the year and made the considerable contribution to our thyroid cancer field one by one. And thank you, and also congratulations. Now, you can see from Ramona's presentation today, right? So BRAF has been known for more than 20 years. And it's very exciting that it has some real impact on our field on the clinical front. And the paper that Ramona just presented from MD Anderson is just one of the remarkable example, right? So in the context of Ramona's presentation today and the context of that study, and today I will use probably about 20 minutes. I will talk to you about 20 minutes to quickly review some of the, I would say, interesting, work in the past related to this field. And I use the title here. I said, when making trouble in thyroid cancer, BRAF mutation is not alone. There is companion TERT. So I will first quickly review some of the work in the past on BRAF mutation, and then the second half of my presentation, I will switch to discussing TERT. For convenience, and I will mainly use the work from Johns Hopkins, since I'm familiar mostly with it. And of course, there are lots of wonderful work, a lot of pioneer work in this field by many investigators globally, right? So I hope we have another time to more comprehensive discover today for the limited time and then for my familiarity. In that regard, I will mostly present the data from Johns Hopkins. Now, I have a conflict of interest to disclose related to this presentation, mainly the BRAF mutation, right, as shown here in thyroid cancer. All right, so let's review some of the stories or some of the work related to BRAF mutation and thyroid cancer. BRAF, just quickly, right? Today, everybody knows BRAF gene, BRAF kinase sits in this MAP kinase pathway, right? So with this mutation, the most common one is the BRAFV600E. That's the most common, and that causes constitutive activation of BRAF kinase, and then with downstream activation of the pathway constitutively, causing trouble, causing oncogenesis or tumor progression. The details will not be discussed today, but just very quickly, right, make this point. Now, this actually, there in 2003, that was a really great year for our thyroid cancer field. And that's the year BRAF mutation was reported or identified in thyroid cancer. There were many studies. You know, if you, some of the people who actually at that time worked in that field, I was also young at that time, today old. So remember those, you know, that year, just exciting. Every day there's a paper coming up on BRAF mutation, right? Johns Hopkins team, as shown here on this field, also contributed to the field. In fact, this paper was the first in the thyroid cancer field. It was the submission, and for the public recording, the record. This paper was submitted 2 months earlier than many of other publication or manuscripts on BRAF mutation thyroid cancer, and I got accepted actually 2 weeks earlier than any other study, although it came out a little bit late. And the paper actually, the work earned a US patent, which this is one of the patent. That's why I disclose a conflict of interest today. And the point is that year, very exciting in the career life of someone. I feel so fortunate to be in that, I would say, era, to be able to work on this field with our team at Johns Hopkins. Very memorable time. Now, speaking of ATC and the thyroid cancer, in the early years, ATC was reported to have BRAF mutation with about a quarter, actually, about 25%. Now, today we know the prevalence of BRAF mutation ATC is a little bit higher, but not that high. So probably about 30, 35%. And based on just the presentation from Ramona, and probably about 35%. But this, even not that high, the prevalence, but this where the hope is in patients with ATC, right? So since Ramona already gave a comprehensive presentation on that, I will not discuss or not repeat. When the BRAF mutation was discovered, in the first few years, there were a lot of reports on the prevalence and the clinical correlation. And the function-wise, actually, the work, the field had been quiet. And this paper from Johns Hopkins, our group, in fact, Lingjie Liu, my early postdoc at that time, we published this paper. The study was simple, cell line, xenographic tumor, but that's a study functionally show that the BRAF mutation not only prevented thyroid cancer causing excitement, in fact, oncologically, oncogenically, BRAF mutation was very important. If you manipulate the BRAF mutation, the mutant, you are able to suppress thyroid cancer cell. You are able to suppress tumor genesis, right? So that's what one of the first studies to demonstrate functionally the importance of BRAF mutation in thyroid cancer. And subsequently, among other studies by others, and our team also contributed to the field in terms of demonstrating that the BRAF mutant was actually a good target therapeutically. So these are some of the publications that our team contributed, demonstrating that the BRAF inhibitor, MEK inhibitor were effective in suppressing thyroid cancer and suppressing thyroid tumor. In fact, in the context of ATC today, these studies use cell lines that were undifferentiated thyroid cancer. So even they had the name of PTC, actually they were undifferentiated. They function, behavior like ATC. In other words, in those early studies from the preclinical experiments, we already knew that targeting BRAF could potentially therapeutically effective. And the work, of course, important, right? And Hopkins also earned a US patent on this work. Today, we all know BRAF, the MEK inhibitor works well, but at that time, there were no clinical data yet. Preclinical data were equally exciting. Speaking of thyroid cancer in relation to BRAF, we cannot forget about the one unique aspect that read-iodine ability loss when there's BRAF mutation. And this is the first study also from Johns Hopkins, from our group, reporting for the first time the association of BRAF mutation with the loss of the read-iodine ability in thyroid cancer. Today, we know very well, right? The field is very well aware of this phenomenon. This is just a clinical association. And subsequently, from a functional perspective, we did some work and demonstrating that when you manipulate BRAF mutant thyroid cell, we actually use not a thyroid cancer cell. This cell also could express some normal thyroid cells, the so-called normal, not necessarily normal, but they still could express thyroid genes like TSHR, NACE, TG, PAX8, etc. And interestingly, when you introduce BRAF mutants, this gene got silenced. And then when you add a MEK inhibitor, there's an inhibitor at that time, I remember what the name, it's called U0162. It's never been, I think this Park Davis inhibitor never been used clinically, but this is good MEK inhibitor used in experimental research. So we were able to suppress the BRAF, the MEK activated by BRAF mutant, and consequently see recovery of the thyroid gene expression, right? Actually, this is the first study showing number one, BRAF was able functionally suppress the expression of this gene. Number two, when you use the MEK inhibitor, you were able to restore the expression. Later we know there are many studies of this type, even in animal, even in human being, right? So this is a hot area where people use the BRAF MEK inhibitor to restore the thyroid gene expression and the read-iodine ability, right? But this is the initial study, and this study also earned a patent. And in fact, in 2007, when the Endocrine Society meeting in the US had the session, so-called the Year of Endocrinology. That session was presented by Dr. Ridgway, who sadly passed away, right, a few years ago. He highlighted this study. And many studies later demonstrate, as I said, some even animal and human. So today we are aware of this mechanism as shown here. BRAF and when had mutation, the active operating thyroid iodine metabolizing system is silenced, and therefore you lost the read iodine ability. And that's also a reflection of differentiation. So the cancer lost differentiation. And just like a thyroid cancer cell line, it's like ATC, again, in the context of today's theme. Now, so that's some of the study long time ago, reflecting what we knew, what we were trying to achieve in those years from a clinical, partially from a clinical perspective, and mostly from the preclinical perspective, right? And of course, we all are aware over the year, there were a lot of studies, have been a lot studied trying to see if there's a correlation between BRAF mutation and clinical outcomes, very active area. There are so many publications. And our group at Johns Hopkins also contributed quite some work in this area. And this is actually the first study that showed the correlation between BRAF mutation and the clinical outcomes, not just pathological characteristics, right? And also clinical outcome. Specifically, this paper for the first time showed a correlation or association between BRAF mutation and thyroid cancer recurrence, and also the loss of read iodine ability. And then later we also have another study. This is thyroid cancer. This is a multi-center study involving more than 2,000 patients. And basically, this study showed a strong association between BRAF mutation and disease recurrence, as shown here. You can see the relationship when you look at the entire cohort of more than 2,000 cases, or if you look at the subgroup with the variants like conventional thyroid cancer or follicular thyroid cancer, you saw the same thing, right? This is probably the largest cohort looking at the relationship between BRAF mutation and clinical outcome. There are also, of course, many reports from other investigators in the world. And mortality. So BRAF mutation, does it have a role in the mortality related to thyroid cancer? This study from Johns Hopkins said yes. When there is BRAF mutation, there's actually significant increase in mortality or decrease in survival. And this figure actually in the published paper, the x-axis cut here, the editor forced us to cut at probably 12 years. But at that time, we have to accept. So in fact, the unpublished parts after 12 years. I want to make this point. Why do I show here? Why do I say this? I want to make a point here. The BRAF mutation, the effect of BRAF mutation on mortality occurred actually after 10, 12 years. And the first few years, there are not much difference between BRAF mutation wild type or BRAF mutation type and the wild type. But after that, if we follow that longer, the impact of BRAF mutation on mortality even more pronounced. I think it's very important because knowing that BRAF mutation does a bad job, but the bad job occurred mostly later. So we need to wait, need to be patient. That's the point I want to make. And the field of thyroid cancer and particularly BRAF mutation, we know there are controversies, right? What I show here, mostly positive, but there are studies that did not show so. In fact, some studies did not see any correlation between BRAF mutation and the clinical outcome. I have some example, like Johns Hopkins here, right? The Xing lab, Xing group, they showed that my group showed that the BRAF mutation were associated with the poor outcome of clinical, the patient clinical outcome. And Martha Dagger, my respected teacher there, I would call a dear colleague, dear friend there, and a mentor. But her group at one point on different patient cohort involving several centers actually, and they show some correlation between BRAF mutation and some clinical parameter, but not all. In fact, in some area that we show, she did not see. And another example, UCSF, like Dr. Cabello, and he published several paragraphs shows strong association between BRAF mutation and poor clinical outcomes. But at the same, studied there in California, I would say, Northern California there, Dr. Olive's group did not see this. And I can give you a lot of example. Why, do we have this situation, right? There could be a lot, when you do clinical studies, a lot of factors. So the type of patient you have, the type of tumor you have, the combination, the components of all the factors could all contribute, right? But multi-variate analysis, a lot of study meta-analysis, almost every meta-analysis shows strong association between BRAF mutation and the poor clinical outcome. But there are, controversial data. Today, I want to actually, repeatedly in recent year, said that another factor, another genetic factor could explain this. That is TERT mutations. So that's what brings me to the second half of my presentation. In other words, we know actually today, I'm sure you guys all know, right? So I think at least most of you know that BRAF mutation itself sometimes may not behave the way that we saw before. You need to have a TERT mutation. When the two mutations coexist, the scenario, the clinical scenario is very different, right? So not a new concept today now, right? But I want to take the opportunity to review this concept very quickly. This is actually the first paper that's also from our John Hopkins group that reported or identified TERT promoter mutation in thyroid cancer. That was in 2013. So 10 years after the reported BRAF mutation, and then there was a TERT promoter mutation. Today, 2024, we just passed 2023. It's just 10 years and 20 years. Interesting number. And that study, not just a report the present TERT promoter mutation. I think very important, perhaps most important finding is that BRAF mutation, TERT mutation coexisted. In other words, you can see from this table, we found that when you have a BRAF mutation, you more commonly have TERT promoter mutation than those cases that did not have a BRAF mutation. And if you have TERT promoter mutation, most of these tumors also have a BRAF mutation. Very interesting phenomenon. Of course, when you present that data at that time, we did not have functional and clinical data to understand why, to understand significance, right? And these shortly after that initial report, we also have a quick meta-analysis. So you can see from this table here, around the globe, virtually everyone report an association between BRAF mutation and TERT promoter mutation. This result convinced us that coexisting TERT and BRAF mutation was real. If it's so common, there must be a biological and a clinical significance, right? With that idea, we were driven to first study the clinical significance. And this is one of the results of that effort. And basically, this is the first study we show that if we have both BRAF and TERT mutation, the clinical outcome was the worst. And here is the results. So in this particular study, not too high cohort, only a little bit more than 500 cases from Johns Hopkins. We were looking at the recurrence-free probability, right? You can see here the black line, the top line represent patient who had no BRAF mutation, no TERT mutation. The recurrent-free survival line still drop. In other words, there are still recurrence, even without BRAF mutation, without TERT mutation. When there was only TERT mutation or BRAF mutation, the curve dropped a little bit. But if we have both BRAF mutation and TERT promoter mutation, the line dropped sharply. So this is the first demonstration clinically that BRAF mutation, TERT mutation together at the genetic date did something, very bad here, right? And this phenomenon also seen when you only look at the subgroup patient with the conventional hepatocellular cancer. How about the mortality? Survival curve here, very similar, and even more clear. With published paper subsequently just looking at the mortality with respect to the BRAF mutation and TERT mutation status. Basically, the top line, the black line, again, represent no BRAF mutation, no TERT mutation, virtually nobody died. When there's no BRAF mutation, no TERT mutation, virtually nobody died. Some of the patients in this group also have a clinical disease, metastasis, for example, but they carried the disease without death. The patient survived, lived well. And when you have BRAF mutation alone or TERT mutation alone, the curve drops slightly. But when you have both mutations, the curve of the line, the survival curve drops sharply, right? The top panel represents analysis of the entire cohort of more than 1,000 cases from Johns Hopkins. And the panel B here represents analysis on the conventional hepatocellular cancer. We have a habit in those years when we did the study. We like to look at the entire cohort of all the patients with thyroid cancer, and then we like to focus on the special analysis on conventional thyroid cancer for two reasons. Number one, that's the most common subgroup, right, or variant. Number two, PTC really have a homogeneous genetic background. PTC, other variants of PTC are often not that homogeneous. Some even, I do not feel is very typical thyroid cancer in terms of genetic background. So for that reason, we often do a subgroup analysis. And when you do a focused analysis on conventional thyroid cancer, often, more commonly, the TERT or BRAF or other genetics, the story are consistent. Amazing. All right. So data, I think those data, and together with many other studies by other people published over the years, clearly established today the importance of the coexisting BRAF and TERT promoter mutation in terms of clinical impact. That's clinical. So as also a basic researcher, basic research scientist, we are also always wonder why at the molecular level, at the mechanistic level. So with that, we performed this study that was published a few years ago in Nature Communications. Basically, we found a pathway or a molecular mechanism that explains why when you have two mutations, the clinical outcome is so poor. I will not, will not have time to discuss the detail of the experimental result. In lieu of that, I will just focus on the lots of figures, a summary figure of that paper to explain how the two mutation works, right? Operate or synergize. Basically, when you have BRAF mutation, as we briefly discussed at the very beginning of today's presentation, you activate the MAPCAM pathway, and then consequently the downstream molecule FOS, which is anchor protein we know, is activated, it's phosphorylated, and we identified that FOS was a transcriptional factor of a gene called GBPB. So GBPB can be upregulated robustly, and then GBPB can form a complex with its partner GBPA, can be dimer, can be tetramer. And in those years, the thinking was simple. Today, of course, more complex. There are also other transcription factors classified here, but FOS as a transcription factor regulating the upregulating GPB is a very important step in this pathway. And when you have a BRAF, when you have a TERT promoter mutation, you create a binding site, a consensus for the complex of GBP, GBP, and perhaps also other transcription factor. Without this mutation or TERT mutation, there's no binding site. So therefore, the mutation is very important for this machinery to regulate TERT. TERT in normal cells have been, is normally silent, right? When you have a TERT mutation, that's abnormal, that's in cancer. With this mechanism, when you have both mutation, you robustly activate TERT. TERT is very well-known anchor protein. Normally, our normal cells, somatic cells, do not have expression. Right? When you have a normal expression, overexpression, there's a consequence, which is oncogenicity. And this study also will also earn a US patent. I want to emphasize in this figure here, this explains the mechanism of how BRAF mutation, TERT mutation synergize in promoting oncogenesis and aggressiveness of thyroid cancer, and in fact, also other cancer we know today. Melanoma is a typical example. When you have both mutations, the clinical outcome of tumor aggressiveness is much worse. This is mechanistic diagram, but I also want to take the opportunity to emphasize the targeting, some of the targeting points. BRAF, we know very well. MEK, we know very well. We add one, FAS, because FAS plays a critical role in relaying this oncogenic signaling to TERT. Therefore, when you target the FAS, therapeutically, I think there's a hope, right, to be promising, which actually is true, as I will show you in just a little while. So given that mechanism, we have the idea, and at that time, a few years ago, that is, we thought BRAF mutation may be, may be insufficient in terms of therapeutic targeting. And let me put the idea also this way. BRAF mutation may not be sufficient to explain the clinical outcomes. You may need something else. With that, with the clinical data, also that mechanistic study I just present to you, it's very, right, so natural to think that you may need both mutations to promote cancer aggressiveness and to generate therapeutic target responses, right? Because at that time we knew clinically, particularly using melanoma as an example, some patients respond so well to MEK inhibitor, BRAF inhibitor. Remember those years, almost 10 years ago, every day there's a Nature paper, Science paper, and neoadjuvant medicine paper, right? So melanoma lethal cancer became curable when you have a TERT, when you have BRAF inhibitor there. But some people didn't have a response, had drug resistance. Some people had primary drug resistance, some have second drug resistance. Our simple idea was that those people who do not have good response, maybe they just have a BRAF mutation, no TERT mutation. And then those who respond well, maybe also have a TERT mutation, not just BRAF mutation. So this PNAS paper we published a few years ago, trying to was designed to test the idea, and indeed, our hypothesis was proven to be true. So this is just one example of data. I will not have time to discuss all the whole data. So here, what you see here, when you have the cancer cell, not just thyroid cancer cell, when you just have a cancer cell with only BRAF mutation, when you have a MEK, a BRAF inhibitor, you suppress the cell, perimeter suppressed, the cell became cytostatic, but no death, right? When you have both TERT mutation and BRAF mutation, you give the two inhibitor in combination, you induce robust cell death or apoptosis. And as shown here, through cytometry here, you even more clearly see when there's no TERT mutation, only BRAF mutation, you do not see much apoptosis, but here you see robust apoptosis when there are both BRAF mutation and TERT mutation, right? And when you look at the tumor, xenographic tumor, the top portion represent tumor only with BRAF mutation. You give it the 2 inhibitor, BRAF-MEK inhibitor, you see clear inhibition, significant but not that much during the course. And the last 2 to 3 weeks, you stop giving drug. And then at the end, you sacrifice the tumor, the animal. The tumor became the same. Initially suppressed, and later you stop drug, and then cancer regrew. In the end, the treatment group and non-treatment group had a similar size of the tumor. In striking contrast, when you have a tumor from a cell that have both BRAF and TERT mutation, even you treat even you stop the treatment for 2 to 3 weeks, the tumor stays small. The reason, the explanation is that because when you have 2 mutations, the drug induces apoptosis, cell died, right? So even you stop drug treatment, you will not see recurrent or regrowth tumor. Maybe you wait half a year, 1 year, or a year, the tumor will regrow. At least within the time of our experiment, we did not see tumor regrowth. So this in vivo, right, approach that showed that the 2 mutation really so important in terms of clinical therapeutic response, right? Now, half a year after our publication, things went so quick. A German group published a paper and testing our preclinical idea, published in that preclinical concept. And they found that indeed, in patient, more than 600 melanoma patients, and they separate them according to their genetic background, TERT mutation alone, BRAF mutation alone, and the combination of BRAF and TERT. In short words, the conclusion that when there was a BRAF mutation and TERT mutation, the patients responded better to BRAF and MEK inhibitors. So exactly recapitulate the clinical recapitulation, right, of our preclinical finding. We felt, when we saw this paper, we felt very excited. Yes, wow, the study, your study was reproduced clinically in patients. As I mentioned earlier, FAST can be a target, new target. Just to be quick, to test this idea, we performed this study, which was published just 1 year after that PNAS paper, also in PNAS. Basically, we target FAST here as shown in that magnetic diagram, right? You would suppress GPB expression, then consequently, throughout the pathway, you suppress TERT. And this same study will also show that TERT had strongly suppressed TR2. For many years, we know TERT is strong suppression of apoptosis. Apoptosis resistance is a common cancer property, universal, right, ubiquitous, and the TERT plays an important role in that regard. But how does TERT suppress apoptosis? In this study, we found that TERT actually suppresses TR2. TR2 is a strong, critical, intrinsic initiator of extrinsic apoptosis, and we were able to link to it. So this explains why TERT could suppress apoptosis, right? When you target FAST, as shown here, you are able to suppress cancers that had a TERT promoter mutation. You are not able to suppress cancer cells that did not have a TERT mutation. When you look at apoptosis, exactly the same thing. When you have a no TERT mutation, as shown here, there were no induction of apoptosis by the FAST inhibitor. When you have a TERT promoter mutation, you have robust apoptosis induced by this FAST. And this is some of the molecular events that, I will not get into detail, but also these results also support that FAST could induce cell apoptosis robustly when there is also TERT promoter mutation.
Dr. Xing, I want to just... Okay.
So basically, what I present to you today, genetic due to BRAF mutation, TERT mutation is double-edged sword. On one hand, if you have it clinically, the patient doing very bad, right? On the other hand, because the cancer cell has evolved to be dependent on this mutation without apoptosis, when you shut down this pathway, you cause robust apoptosis. I call this genetic dude an Achilles heel. The important question I have here today with respect to today's ATC theme. Today, nobody looked at the genetic dude and terminal response in thyroid cancer, although people did this in other cancer like melanoma, right? So my question is, do we think people with thyroid cancer harboring both mutations may actually respond better to MEK and BRAF inhibitor? You know, this will include ATC. I hope, Ramona, you could have a chance looking back your data, including also TERT. My take-home message today, when making trouble in thyroid cancer, BRAF is not alone. There's a companion, TERT, and we'll remember this, right? And these collaborators over the years, when I have time to mention everyone, but I want to collectively thank them. And these people in my group over the years who made such a huge contribution. And this is where I am today. Thank you very much, Ramona. Thank you.
Thank you so much, Dr. Xing. This is just incredible. I think we could spend 2 more hours here, but we have to give people back their Friday. So I just want to come back and congratulate you both and echo everybody that has been sending in questions and commenting on wonderful presentations from you both. I think the common theme today is resistance. There are some questions. I'm sorry that we will not be able to get to them all in right now, but there's a couple of questions, as in, did you find any common denominators or any characteristics that were common in patients that did not do well after neoadjuvant therapy? That would be the first. And the second, Dr. Cabanillas very kindly asked, can you comment on the patients that had primary resistance with D plus T and what we know, going back to the common denominators? And can you comment on the order that we should be starting drugs? Dr. Xing was commenting on TERT mutations as a companion and as an adverse factor to the prognosis of these patients. Do we have a sequential treatment? Do we have something that we could share with people that would be a take-home message in the sequence and the way that we should treat people? Dr. Dadu.
Thank you so much. And I was trying to keep up with these excellent questions in the chat and try to respond to most of them, but everybody is very excited and interested, it seems like, so that's great. So a few comments that came through from the question, and I want to re-emphasize. Currently, the sequence of how we treat these patients is that we will start dabrafenib trametinib typically. We will use that as a run-in period for about 3 weeks, 3 to 6 weeks if there are insurance delays for pembrolizumab. We allow that run-in to monitor for the initial toxicity of the BRAF-targeted therapy. We add the pembrolizumab at a later time, but trying not longer than a month after restarting DT. We restage this patient very early to have the opportunity to catch that early significant response. Just before the 3 months mark, we restage and try to offer them surgery immediately. For those who did not have such an impressive response initially, we may allow them for another 6 to 12 weeks on drug and reassess resectability at 6 months. But typically early on, at about 3 months time frame, everybody has that significant response that could be followed by surgery. We do restart dabrafenib, trametinib, and pembro the week after surgery. We get surgical clearance from our colleagues and 5 to 7 days restart the regimen. That gives us some time to plan for the post-surgery treatment in some of our patients in which we offer radiation, and this is only for patients 4B at this time. We do not usually offer post-operative radiation for 4C. For those who are recommended for post-operative radiation, we restart the drugs so that allows us for timing to plan for that radiation. Radiation usually begins 2 to 4 weeks after surgery, so we do not want these patients to go for 2 to 4 weeks with no drugs. We do stop the treatment during the radiation. However, there are now at least 2 clinical trials trying to assess the safety and toxicity of using the BRAF and trametinib with radiation. So when at all feasible, we try to enroll patients on those trials and keep them on systemic therapy with radiation. And after the radiation is completed, we, if we haven't used the drugs during radiation, we restart the drugs. All 3 of them, the dabrafenib, trametinib, pembrolizumab, after the radiation. There are a couple of patients, this is very uncommon, that have primary resistance to dabrafenib, trametinib. In these particular patients, 9 out of 45 did have primary resistance, and they were not able to be resectable. We did not look into a whole lot of details in these 9 patients on this paper, but in my clinical experience, the ones who do not respond, that very rare scenario, is primarily those who have coexisting mutations, especially in the PI3 kinase on that mTOR pathway. So if there are coexisting mutations with BRAF PI3 kinase, those are the ones who tend to have less response to BRAF targeted therapy. And I hope that answered all the questions in the chat.
Yes, certainly. Thank you for that quick summary and that response. I have many more questions to go through. I have some from the audience as well that I've gotten into my email. I will be sending those to you in an email if you don't mind. I am really happy to have you here. Thank you both. Thank you both for carving out some time to be here with us today. And I do want to invite the rest of the audience to be back with us next Friday. We'll be having a little bit more honing in on molecular diagnosis and novel panel that is out there to evaluate patients with intermediate thyroid nodules. So thank you all. Have a great weekend. Be safe. Thank you for your time.